Hello and welcome to today's webinar, Serving Patients Experiencing Homelessness in Hospital Systems. I'm Caroline Gumpenberger and I'll be the moderator for the webinar presented by the National Healthcare for the Homeless Council. This is a 60-minute presentation with the last 10 minutes reserved for Q&A. There is a chat box below the presentation slides for participant questions and technical issues. Please type your questions or technical issues into the chat box at any time during the presentation. A select number of questions will be answered at the end of the presentation during the Q&A session. Remaining questions will be logged and provided to the presenters for written responses after the webinar. If you are having technical issues, you may also call the Council's office at 615-226-2292 for assistance. Our presenters today are Bobby Watts, Chief Executive Officer of the National Healthcare for the Homeless Council in Nashville, Tennessee, Kevin Lindemood, President and CEO of Healthcare for the Homeless in Baltimore, Maryland, and Brooks Ann McKinney, Director of Vulnerable Populations at Mission Hospital System in Asheville, North Carolina. And the learning objectives for today's presentation are that attendees will be able to describe the history of the Healthcare for the Homeless program and how hospitals have participated in HCH programs in the past, implement strategies to develop relationships between hospital systems and HCH programs, and engage hospital systems and have conversations about coding, care coordination, and possible funding opportunities. And now we'll switch it over to Bobby's message.
Thank you very much. I want to say I'm very honored to be here, and I look forward to this webinar with Trinity and look forward to continuing to work with Trinity in the future. I want to talk a little bit about the Council. I want to talk about why we exist, our history, how we got here, who we are, and what we do. So you can see that the mission of the Council is to eliminate homelessness by ensuring comprehensive health care and secure housing for everyone. Origins of the Council go back to 1983, when homelessness was first exploding in the national consciousness, and two large foundations decided they wanted to see if effective ways could be found to deliver health care to the growing number of people experiencing homelessness in our country. In 1985, they created the Healthcare for the Homeless program by funding 19 demonstration projects, one in each of 19 cities. And the program was so successful that in 1988, the federal government decided that they wanted to take this program and replicate it and create the Federal Healthcare for the Homeless program. When that happened, the original 19 programs saw the value of continuing to network together, to learn from each other, to share best practices, and they created the Council. As things continued in 1991, they hired the first executive director, John Logier. There are now over 300 Healthcare for the Homeless grantees, at least one in every state, plus the District of Columbia, plus Puerto Rico. So the Council is comprised of over 200 organizational members, 4,000 individual members, and these are organizations and individuals that are on the front line of providing health care, housing, social services to people experiencing homelessness, and very important, a number of our individual members are those with lived experience of homelessness. The work of the Council is spearheaded and aided by a great staff. We have 20 staff in Nashville and 3 in Baltimore, which is our policy team, so they can be close to Washington, D.C. The Council does its work by those on the front lines organized in several committees. In addition to the committees, we have 3 large networks: the Clinicians Network, the Respite Care Providers Network, which is the preeminent body of information and practitioners of those providing medical respite care in the whole country. And we have our National Consumer Advisory Board, which helps the Council and our members and everyone in the HCH community ensure that the voice of consumers, those with lived experiences of homelessness, are involved at every level of decision-making in the organizations. And our work is done in three main components. We have a very vibrant and powerful training and technical assistance arm. We have wonderful trainings, we receive inquiries, and we provide answers to those seeking technical assistance. We have an active research arm, and we publish a great number of documents, of studies, of briefs, and many of them are on our website. And to fulfill our mission of eliminating homelessness, we know we have to go beyond providing high-quality care to individuals. So we engage in policy analysis and advocacy so that we can effect public policy to ensure that everyone has access to health care and housing. Thank you very much in your partnership with the Council, and I look forward to working with you in the future. Thank you.
Great, and now we'll pass it over to Kevin Lindemood. Kevin?
Thank you very much. Good to be with you all today, and good to hear that history from Bobby Watts. I'll put a little more meat on the bones, if you will, of that history from a hospital perspective, because very much the story of the emergence of healthcare for the homeless as a national model involves the hospital community and one hospital in particular. I'll take us back to the late 1970s and the early 1980s. New York City was really the first city in the country to experience the reemergence of homelessness at levels not seen since the Great Depression. And there was a doctor operating out of St. Vincent's Hospital in New York by the name of Phil Brickner, who in the late 70s was doing house calls, home visits to very low-income communities. And by the early 1980s, started to see in the emergency room people experiencing homelessness, coming in with all of their belongings on their backs. The emergency room doctors would write prescriptions and people would not be able to refill them. And he created in the emergency room and separate from it a healthcare for the homeless clinic to begin to try to understand the needs of what at the time was considered an emerging population. As the story goes, by 1983, the date that Bobby mentioned, the vice president of the Robert Wood Johnson Foundation was visiting New York and was going to an appointment and crossed the street. And he and his wife experienced something that today all of us would take as routine. But back in the early 1980s, most of the rest of the country was not experiencing this, and they literally had to step over someone who was lying in the street. And they said to themselves, oh my goodness, what in the world is going on in New York? This should be alarming to us, right? Unfortunately, it's not so alarming now, but they get to their appointment and the person says, oh, yes, you need to speak to Dr. Philip Brickner. He's at St. Vincent's Hospital, and this is the work that they're doing. And a meeting was arranged, and a conversation happened. And out of that conversation emerged a national research demonstration project. Dr. Brickner and his team were tapped by the Robert Wood Johnson Foundation to lead up that research demonstration project. This was an initiative that grew out of a community-based hospital. That then was taken and spread throughout the rest of the country, of course, with all of the applications. And as Bobby mentioned, there were some 45 applications and 19 projects were originally chosen. They all had to be community-specific and to respond to the needs of their particular communities. For 3 years, that team oversaw all of those projects. And then by 1987, the federal government passed something called the Stuart B. McKinney Act, which was really the nation's first contemporary response to homelessness. And in addition to some shelter programs and some housing-related programs, it created in law the Federal Health Care for the Homeless program. And those 19 Robert Wood Johnson Foundation projects served as the model. Each of those applications had to be community specific, but they had to involve community collaborations. And so from the very beginning, across all 19 of them, hospitals were at the table, along with health departments and other community health centers. And so I would argue that hospitals have been at the table from day one. We can advance the slide, please. I seem unable to do so. There we go. This shows you the Healthcare for the Homeless grantee profile using federal data from 2016. And so today there are close to 295 Healthcare for the Homeless grantees throughout the country. So this little pilot project grew a very large operation. The majority, and what this slide represents is some of the special needs programs in addition to community health centers. So you see HO, which means homeless only. You see migrant health centers and public housing health centers. But the general overview here shows you that the large majority of healthcare for the homeless programs today are located in larger community health centers. About 20%, 19% here are what's called homeless only or standalone healthcare for the homeless programs. And then what this slide doesn't show, but is important for this audience, about 25% of all healthcare for the homeless grantees are either based in health departments or in hospitals, or as we'll talk about, and as some of you know, some hybrid of the two models. Today, the National Healthcare for the Homeless Council has about 225 organizational members. We have hospital affiliates, 11 hospital-based healthcare for the homeless projects in these particular states. 9 non-healthcare for the homeless recipients are nonetheless hospital members of the National Healthcare for the Homeless Council. And I would argue that all healthcare for the homeless projects, because frankly it's a federal requirement, have close relationships with at least one local community hospital, if not many, in their communities. Let's look a little bit at Trinity Health and National Council membership. So in addition to Trinity itself as a corporate member, the hospital systems within Trinity are increasingly becoming National Council members. Here are 2 that you see, Lord's Health System in New Jersey, Loyola University Medical Center in Illinois. These continue. There are more that are coming online. There's 3 noted healthcare for the homeless projects that are based in Trinity member organizations. Mercy Medical Center in Springfield, Massachusetts. Doreen Fadis was a past president of the council, long affiliated with that program, though she now has a larger role within the hospital system. But the healthcare for the homeless grantee there is actually in the public health department and then subcontracts through the hospital. You go to Atlanta, Georgia, Mercy Care Services used to be affiliated directly with a hospital that was a Trinity hospital. That hospital was then sold, and Mercy Care Services became its own entity headed by Tom Andrews that some of you may know. He is both a member of Trinity and a member of the National Healthcare for the Homeless Council. Of course, there's the great work of Jim Withers, who's been doing incredible work with a field known as street medicine, and heads up a international street medicine institute that's based in something called Operation Safety Net in Pennsylvania as part of Pittsburgh Mercy. Then there are, of course, hospital partnerships throughout the country. All Healthcare for the Homeless projects, all community health centers are required to have hospital relationships. Some of note, the Minneapolis Healthcare for the Homeless program comes through the county entity again in Hennepin County, but is directly based and operates in area hospitals. So many healthcare collaborations that we'll continue to talk about. Also some emerging housing initiatives. The Chicago Healthcare for the Homeless program, the Portland Healthcare for the Homeless program, both involved in really innovative and interesting housing initiatives. In the case of Chicago, to directly keep high-cost users out of the hospital, there's been some data shared and some national press work that's easily findable if you're interested in more information about what Chicago is doing. Also, Portland, the hospital is actually putting up bricks and mortar money to fund housing because it's deemed so effective. Thirdly, in addition to healthcare collaborations, housing initiatives, there are a range of respite care partnerships throughout the country. And in fact, in a recent survey, nearly 60% of the respite or convalescent care programs that we are aware of at the National Council through the Respite Care Providers Network, about 60% of them receive funding, in most cases a significant amount of funding, from area hospitals or hospital collaboratives. So these are, when we think respite care or convalescent care, it's essentially home care for people experiencing homelessness. So if you're in the hospital and someone's sending you home to recuperate, if you don't have a place to go, you're not going to heal, you're not going to get better in a traditional overnight shelter where you have to leave at 6 o'clock in the morning. And so these are collaborations to provide intensive care so that people can heal from acute or chronic illnesses. Lifelong medical care in Berkeley, California, one to look at. Circle the City in Phoenix, Arizona. McGinnis House in Boston is really a flagship respite care program that more than 20 years ago was able to have it financed through Medicaid, which is really fantastic. Many of us look at Boston enviously. Financed through Medicaid, and then they enjoy very strong partnerships with their area hospitals that routinely refer to the respite care program. Circle the City in Portland, Oregon is another very interesting emerging model. I'd like to talk a little bit about healthcare for the homeless here in Baltimore, and we were one of the original 19 Robert Wood Johnson Foundation projects. And so we have had a history of historic formal partnerships with hospitals. Out of that very first grant in 1985, we partnered with Mercy Medical Center here in Baltimore, which is affiliated with other Mercies, some of which are in the Trinity system, even though Mercy in Baltimore is not a formal part of the Trinity system. The University of Maryland, another hospital very close to us, and Johns Hopkins. Johns Hopkins provided mental health services. Mercy provided medical services. So for a long time, and certainly for the first 3 years of the grant, all of the medical or mental health staff came through those hospitals. We would pay the hospital would pay the employee, and would provide them for the partnership. There were great benefits for that kind of association over time, particularly in the years between 1985 and 2014, because the large majority of the adult population that we were working with were uninsured and not insurable. So this was the single childless adult population that was not eligible for Medicaid in Maryland or anywhere in the country. And so it became very important to have formal partnerships with those entities, particularly Mercy Medical Center. So we maintained, even as we became incorporated as our own nonprofit, even as we grew over a period of decades, we maintained that contractual relationship where we hired the majority of our medical staff through Mercy. Because Mercy saw us as a part of them, they provided all of the labs and x-rays to our clients, even those who were uninsured. They leaned on specialists within their network, people that had their offices at a Mercy facility, to encourage them. Think about the Catholic hospital in your area, the one that you're affiliated with. When in Mercy, the real leader is a woman named Sister Helen Amos. And when Sister Helen comes to your practice and asks you to see uninsured clients of healthcare for the homeless, you're not going to say no. And so that created incredible access for an uninsured population to services. We had a similar arrangement with a program operated by Johns Hopkins. We still maintain both of those referral arrangements, but what happened in 2014 in Maryland, which is a Medicaid expansion state. I realize that this experience doesn't translate to parts of the country that did not expand Medicaid, unfortunately, but we went from 30% insured to 90% insured. And so suddenly we were not referring as many uninsured people. Because we actually had referral networks through Medicaid and could get people access to the specialty services that they needed. And so we began a period of really looking for new ways to expand hospital alliances. Mercy, for example, helped us approach some of their donors to raise money for the capital side of a mobile program that we launched to take our services out into the broader community. Bon Secours Hospital deep in West Baltimore, in a very poor and underserved part of Baltimore, very close, not far from where the Freddie Gray incident of a couple of years ago that made national news is. We were able to, with Bon Secours, start a healthcare for the homeless clinic in some decommissioned hospital space directly in the hospital. And that's a 2-year program now that's been operating very, very effectively. With Mercy and other area hospitals, we've done emergency department diversion initiatives. We're part of a collaborative now that has allowed us to double our own respite care program, which we call convalescent care. It's small, from 12 to 25, but they are funding the additional staff resources that make that possible out of Maryland's somewhat unique all-payer hospital system. So the hospitals are actually paying for that expansion. And on Friday, our chief medical officer and I are going to the community benefit meeting of all of Baltimore's hospitals at their invitation to talk about housing. They would like to have a conversation about the relationship between housing and health and how they might do more to house some of their most vulnerable high-cost users. In Maryland now, rooted in strong relationships with hospitals, we believe that there's a new frontier that we can explore in that because of Maryland's hospital situation, there is a rate-setting commission that sets the rates for all hospitals, and it's done through a unique Medicare waiver. All hospitals in Maryland now are operating on global budgets. And so this is facilitating the conversation about community-based care and about interventions like respite care and housing in a way that we've never been able to advance those conversations before, because now it does directly relate to their bottom line. And so these are really interesting conversations that await us. In terms of some strategies for collaboration, what we know in the healthcare for the homeless field in general is that all of our clinical work is about relationship building, establishing relationships with people, and then moving from there. And that can sometimes be a long process. But just as we start where our clients are clinically. It's really important to start where our community partners are. And so when we discuss strategies to improve hospital healthcare for the homeless relationships, these could be strategies used by Healthcare for the Homeless projects wanting stronger relationships with health centers. They could be used by health centers wanting stronger relationships with hospitals. One of the things we found with Mercy, for about 20 years, Mercy ran for us our children's program. So they actually hired within their umbrella nurse practitioners and social workers to go out into family shelters and work with kids. For years, that program didn't feel a part of the broader hospital, and they didn't feel a part of Healthcare for the Homeless, of us. And they would approach us and they would say, we want to be under your umbrella. And they would approach the hospital and they would say, we want you to treat us like we're more a part of your system. We ended up bringing that program to a new facility of ours and launching our own pediatric and adolescent program, particularly when the emerging needs of kids and families became greater and greater. But the point being there is that even if a project is based in a hospital, that doesn't necessarily mean that that project has good relationships. And if that project is based outside of the hospital walls, it doesn't necessarily mean that either. So this could, these strategies could go in all directions. Board membership is a wonderful strategy, making sure that the hospital boards have members and leaders of community-based organizations affiliated, and vice versa. Every Healthcare for the Homeless project in the community should have high-level representation from their area hospitals on the governance level, on the board. And these are conversations that can be furthered if they don't exist already. It's amazing what hospital departmental meetings or clinic departmental meetings can do to build relationships. You can invite people into them in both directions. As we've been building relationships here in Baltimore, we've had many times where our clinical staff will go and do rounds with hospital staff. And that gives them the opportunity to talk about strategies of meeting the needs of very vulnerable populations, actually participating in clinical rotations, ensuring that health centers are sites, especially in teaching hospitals, for residency rotations. Having hospitals convene health center roundtables, something both Mercy and Johns Hopkins has done over the years, and Mercy is doing currently, is on a regular basis, sometimes monthly, sometimes quarterly. They convene the clinical leaders and the executive leaders of all of the area community health centers to discuss common issues and to develop strategies for solutions. These are ways to build relationships that then result in more formal partnerships down the road. Identifying synergy with mission. Everyone in the Trinity Healthcare network has wonderfully compelling, incredible missions. That's a way to engage with Healthcare for the Homeless projects that are about reaching the most vulnerable. And I think there's wonderful opportunities to identify points of intersecting values. We've had opportunities to share donors. That's particularly helpful when the hospital shares donors with the Little Healthcare for the Homeless program. But that works because there's a mission alignment. And if appeal to mission doesn't work, there's always appeal to bottom line. And this can both be a way to approach for a hospital to approach a community health center, or in the other direction, high-cost users. There's so many missed opportunities right now to identify high-cost users that are experiencing homelessness and develop better interventions that are helpful to the hospital and fulfill the missions of Healthcare for the Homeless projects. And it's all about increasing linkage to community-based care. Meeting mutual needs and starting where people are. We've been able to enter into conversations with hospitals that might, for example, want to prioritize 911 calls. We might not be the least concerned, have any concern with 911 calls, but if we begin where that person is maybe we can improve a system for our clients and develop a better relationship with that particular institution. Then, of course, there's the level of leadership and governance, and I am so struck by the work that Trinity has done with a formal assessment and a performance improvement process. And I have included here as a resource both Trinity's scorecard. Most of you on this call likely have seen this document. If you haven't, I encourage you to do so because your leaders are holding themselves accountable for it, along with a Healthcare for the Homeless example book that was produced by Trinity to help guide its member institutions. You also have in that room a policy brief on respite care financing that looks at what hospitals do in that area, as well as a brief from America's Essential Hospitals on particular collaborations. And I'll end with this. Housing is healthcare. And there's this growing understanding of the relationship between housing and health. I think it's a very exciting one. We're coming to understand housing as a health problem and housing as the very foundation for health, not as the end of some process where someone finally gets housing, but as the first step and is something that's necessary to improve health. There's, of course, a broad focus on social determinants, on moving toward accountable care organizations that many of you have been involved in. This all goes in this very same direction. Medicaid expansion in Medicaid expansion states has really caused us all and caused hospitals to realize that these are individuals that have resources attached to them. And particularly in a state like Maryland, where we've got a global budget, it causes us to think about how to use resources more effectively. There are a range of interesting waivers around the country where states are asking the federal government to pay for housing. The state of New York has asked for a Medicaid waiver to pay for housing construction more than 5 years in a row. It's been denied 5 years in a row, but the interesting thing is that they're using state-only Medicaid dollars to build housing anyway because they know it's effective. Hawaii has introduced legislation to allow physicians to write prescriptions for housing. These are just a couple of small examples of what we're seeing popping, where policymakers, hospitals, local leaders are recognizing the extent to which housing is, in fact, healthcare. And with that, I will turn it over to the wonderful Brooxanne McKinney.
Thanks, Kevin. So I'm Brooxanne McKinney, and I'm in a Mission Hospital in Asheville, North Carolina. And just to give a little perspective, our system has 6 hospitals and over 250 clinics. At the main hospital, we have 800 beds, and system-wide, we have over 10,000 employees. So we are the only nonprofit hospital in Western North Carolina, but we are the 6th largest in the state. And I've worked for this hospital system since, well, it's been a little over 5 years. And when I moved to Asheville was when Medicaid did not expand. And so that changed a lot of things, especially in the other states that can understand that we had to start getting creative on how to get funding, especially for the homeless population. And just so you know, before I was in the hospital, I was in the HCH respite world, medical respite. And so I have the perspective from the outside as well as the inside, now being an employee that is looking at the entire vulnerable population of the Western region. So just to go over community benefit, and then we'll get to some more detailed stuff, just so to also give more details to what Kevin was speaking on. But with community benefit under the ACA, the Affordable Health Care Act, tax-exempt hospitals are required to provide community benefits, and there's over 50% of the hospitals in the U.S. have this status. So the IRS guidelines define the concept of community benefit to address those community health improvement efforts and addressing the social determinants of health, and they're all reported on the IRS 990 form. So all of these hospitals have a selection process and have an implementation plan, and many systems have a grant proposal process, all depending on how they decided to implement it. Also, it depends on the large population of the community and how to address those needs. And one of the requirements is the Community Health Needs Assessment, the CHNA, and with those needs is how they can choose agencies to meet the requirements for the IRS. And most of the needs are what HCH projects, as well as medical respite programs and other homeless agencies, they meet those needs for community benefit. So nationally, we're just seeing more and more HCH programs, as well as respite and other homeless agencies are addressing the needs in the community health needs assessment. So it's just very important that we all know those needs, because those are what are going to build up the infrastructure for people in poverty in your community or region. So with coding for homelessness, if you're not doing this already in your hospital, it's under the code Z59, and it's an ICD-10, and it's currently already in the system. And I just know from when I first breached this topic in our administration, they didn't really know about it, but also didn't realize it was just a matter of making sure that the administrator or the CMO educated the physicians or whoever is coding, just depending on what kind of system you have. And another way to find data, especially if you're looking for data on homelessness or people in poverty, is that you can pull homeless identifiers in EMR, or you can look at addresses of shelters. When I first started, I would have to look at 19 North Ann Street. That was the shelter that everyone gets their mail at, but also it's the main agency in town. And when we drew that address out, we from the beginning saw over, I think it was the first year, over 500 homeless identifiers. So there's just ways to be creative with that, and it's important to get that data to look at ways to fund with community benefit, but also for the hospital system to see how they can address those determinants outside of the hospital walls. So making the case, and this is really looking at from an agency standpoint, but also within a hospital system, what is the best way to address these social determinants and how to get this data, and also the return on investment. So just gathering the data on the patients that are frequent flyers, and then proving the number of admissions pre and post, receiving care at a HCH project or another clinic or any other agency that may be creating the intervention of housing or health care. And this will show the pre and post cost, as well as the number of readmissions. And with the new CMS guidelines with discharge planning and all of the regulation with readmissions, this can really show how different agencies can provide a successful intervention. So if possible, showing the cost of pre and post, but just remember that sometimes one outlier can throw off the data, and so I always suggest looking at the number of readmissions, because if you do have an outlier that just came in one time after they started getting care or getting housing, it can throw this whole thing off just because they had a surgery. So just make sure that you're aware of that when you start getting data and cost. And most of all, you all might know the difference of real cost and then charges as well, because a lot of times we'll have agencies come to us and say, hey, we saved you this much money, but that may be the charges cost, not really the actual cost. So just making sure you're aware of that. Just looking at really having stories of consumers and that have successfully gone into housing or into medical respite, and just letting someone come before your staff and just say, this is how my life was before I received care at the clinic or before I was in housing. One story may change a perspective and open a door for funding, as well as open up doors to relationships with other agencies so that the clinicians, physicians, administrators understand why this project may be important. So looking at engaging patients in care coordination, making sure that agencies and clinics meet with the head of case management or discharge planners, just depending on who is doing the discharge into the community, as well as brainstorming ways on how to connect to the patients before they are discharged. Looking at referral systems and just really supporting discharge planning standards. I think the more that I have explained to agencies we work with, this is why this is important, so they don't think that we're just making up things, but also to really be creative on ways that someone can get a face-to-face interaction before they leave. When they're at bedside, a lot of times if they need a community outreach worker, a peer, someone, they'll 90% be more likely to show up to that next appointment. So just really trying to think outside the box when it comes to that so that the relationship is formed. Also, just making sure within the hospital that the discharge planners have updated referral mechanisms. Also, just with phone numbers, I make cheat sheets all the time for the social workers just so they know which agencies can be called, and also how to make sure that they do get an appointment within 2 weeks. Is important with their medications. Sometimes the local FQHC can be the only place that someone can receive integrative care, including mental health medication. So just making sure that the patient understands why it's important that they go to their follow-up. So looking at relationships, having a champion in the hospital that can start advocating for patients experiencing homelessness, and you may have a whole team of people that do that, but I know that when I first started within the health system, no one really understood why it was important. But also just having someone that can push the discharge regulations as well as the community partnerships, and having that data to prove that the agency or clinic can be a positive return on investment is important. So anytime that you have an agency come inside, that they're prepared to say, hey, this is what services we give. And making sure that administrators get out into the community and see the sites that there may be homeless services, but also any permanent supportive housing projects, as well as the agencies. A lot of times in a hospital system, the administrators have not gone outside the walls, and so they don't really see how a successful project looks, or they have never heard a consumer story on how once they came to the clinic, they got all of their needs addressed, and then they didn't come back into the hospital. So the more that you can just start that conversation can really support the relationship. But before I go on with the question and answers, I just wanted to touch on different ideas with relationships and coordination of care. I touched on the in-reach with agencies coming bedside, but if there's a PATH team in your community, as well as some type of outreach team, making sure that they come inside and meet the clinicians. Like if you have a lunch and learn, as well as grand rounds, getting the agencies to come once a month and meeting the clinical social workers, as well as anyone that may be doing discharges. But the more that they can form that relationship, they'll make that phone call to allow the follow-up appointment. Looking at community benefit funds, medical respite, we personally, we at Mission Hospital, we support the medical respite beds, but also with community benefit funds, we fund the agency as well as services that go into permanent supportive housing. So really just looking at that relationship with your community benefit department as well as the agencies that may receive funding from that. Making sure that patients have their appointments soon, but also that when they have those appointments, if they're going into housing or work with the housing agency, letting that case manager know that they have that appointment coming up, but also the more that you can work with the housing voucher agency will allow that coordination of care to happen, so that sometimes I've seen patients that were in the hospital for 3 weeks, and during that time their housing voucher came up on top of the list, and so they were discharged right into housing. So the more that you have those relationships with those agencies, you'll see someone sometimes go right into an apartment because they did qualify for a housing first voucher. Also, getting someone from the hospital system to come to local homeless coalition meetings or get involved in the housing authority. Kevin touched on this a little bit, but the more that the healthcare side of things can get involved with the housing piece, then you can see different opportunities for investment, especially with permanent supportive housing. An example we have in Asheville, there was a collaboration between the hospital system, city, county government, the main homeless agency, and a lot of the various shelters. And it took about 2 years, but we developed a housing project for 16 high utilizers, and all of those patients that were targeted that were the highest utilizers of the hospital as well as the jail system. They now in 1 year have had a 100% retention rate, and so now we're being able to prove over that 1 year how much cost savings was in the community as well as with the hospital. So the more that you can have those someone from the system involved in the housing authority or the continuous care agency meetings, and they can really be a part of that discussion, not just for funding, but also working out ways on how you can make sure that those patients, if you are using the homeless management system or if you're doing coordination of care with coding, those patients would line up. And so over time, you can prove that because you're coding the data and seeing the patients that had the highest needs, if you put them into housing, over time, you'll show the cost savings, not just for the hospital, but for the entire community. So just being really involved in that, and also the return on investment is very important. But at the end of the day, I really think it saves people's lives, and I don't think we could stress enough about housing being health care, because every day for myself, I see patients come in the emergency room that have practically almost frozen to death, but they have so many meds, they have all these things going on in their life, and if we can be the hub for that in the healthcare system and get them into housing, into a primary doctor, we are saving people's lives. So I think that's the most important at the end of the day. So with that, I will pass it back to Caroline.
Great. Thank you so much for your presentations, Kevin and Brooks-Ann. Now we'll start the question and answer period. For our attendees, if you haven't already, please feel free to enter your questions into the chat box below the presentation slides. So our first question, I believe, is for Kevin, which is, can you explain more on the prescription for housing?
Absolutely. If you don't know of a man by the name of Senator Josh Green, a state senator in Hawaii, I encourage you to find out more about him. He introduced legislation last year in the Hawaiian General Assembly that classified homelessness as a medical condition. Now, some of us, and I probably would take issue with that. I think it's a social condition more than a medical condition, but it specifically would allow doctors to prescribe housing for individuals diagnosed as experiencing homelessness, and it furthermore directs 2% of the state's Medicaid budget to housing for people without homes. Barbara DiPietro, the Senior Policy Director for the National Healthcare for the Homeless Council, had the opportunity to interview him recently, and it is the featured story in the most recent Healthcare for the Homeless Mobilizer, which is on the National Council's website, www.NHCHC, stands for National Healthcare for the Homeless Council.org. And it's a compelling conversation with him on this subject. He has spoken with a range of audiences, including, as he notes, Rush Limbaugh and National Public Radio. And one of the interesting things he says is Rush Limbaugh liked the concept because it was focused on cost and it saved money. And NPR liked the concept because it ended homelessness. And he's really about trying to appeal to both sides here. But it does force this question. You know, we can prescribe medications that cost thousands, and yet there's really no health care intervention that we can provide that isn't made 1,000 times better by rooting that care in housing.
Great. Thank you, Kevin. And our next question, I believe, is for Brooks-Ann, which is, how is the respite home funded?
Actually, the medical respite program is at a local faith-based, it's a church, but it also has a building behind it. And the organization started its own 501c3 for respite care and had some seed money, and they actually received money from a couple of foundations, as well as they have a case manager that is full-time. They're on site that actually was included in a new access point application with an FQHC. So that's sort of like an in-kind donation. And then the community benefit within our hospital system gives a annual, I think it's around $50,000 a year to the respite program. So there's multiple avenues of funding, which that's what you see nationally with most respite programs. Either a hospital will fund a large portion of it, or depending on the reimbursement, if they have that at all, if they have a contract with an MCO, that's also a different way of funding. But then in the states that are non-expansion states, usually there's different ways that funding can happen. But I feel like ours is one of the few that have allowed, in the new access point, allowing that case manager to be on staff, which really helps with coordination of care from the hospital, because that case manager is that point person. So I hope that helps.
Thank you, Brooks-Ann. And our next question is, are there any provisions being made for homeless individuals without identification or a way to establish identity who have not been able to obtain health insurance and who may or may not be in this country illegally?
So identification to receive insurance? Is that what you're asking, Cameron? Because it's different.
Believe identification to receive insurance, yes.
Okay. Well, I know that there's different ways to request. Like a lot of times, though, it does cost a small fee unless there's an agency that has a contract with the city or county to help with birth certificates or getting ID, state-issued ID. When it comes to someone, I mean, they wouldn't really qualify for insurance. Like in our state, it's different as well, so that is a state issue. But just help, like having a case manager help with the paperwork and all those details that they need. But like in my state, they don't qualify 200% below poverty level. Kevin, so you should probably speak on behalf of your state since you do have expansion.
Yeah, I'll speak to that a little bit. It's a complicated question. There have been many initiatives And many initiatives, particularly in Baltimore City Council, where council members want to do a local city ID to try to get people access to services faster. Those haven't really gone anywhere. I think for those who are documented and eligible, focusing efforts on getting legitimate ID, very challenging with homeless populations, of course. You have to have ID in order to get ID, but working on better ways to do that, to get people eligible for insurance. The biggest failure of the Affordable Care Act, of course, in my opinion, is that it didn't cover people who were undocumented. The great thing about community health centers is that FQHCs, Healthcare for the Homeless projects, are not permitted to turn anyone away for any reason. And so we do serve undocumented people. We don't focus on identification for them, nor do we, we've had federal reviewers in, and they generally, they know that we can't turn people away, and they tend to not ask those questions. We did have one reviewer. We've heard from some in our networks where some of those questions have been asked, and those questions are generally not answered because we're legally not allowed to answer them. So that's a challenge that we've not solved yet as a country, and especially in a Medicaid expansion state, which we are. We've seen a lot more pressure at not just healthcare for the homeless, but community health centers in general for the uninsured and uninsurable population.
And Caroline, I'd like to add, not just with identification for insurance, but sometimes even in local shelters, if they do need an ID, we've worked out sort of agreement with the larger agencies to allow people to maybe use their discharge paperwork as their ID, as well as sometimes us just calling and saying, hey, this person doesn't have an ID, because a lot of times they can't even get into a shelter with an ID. So working with the agency specifically and figuring out some way that you can have an agreement. But when there's code purple, or when they call emergency beds at other shelters when it's 32 degrees or below, we've even had issues now where they're still asking for ID. So a lot of times I have to advocate to get a bed. So having that sort of point person in your hospital to talk to the agencies when that happens to make sure that someone does get a bed. But that's just always an issue, identification, not just for insurance and everything else, but also when they are trying to get into a shelter bed.
And I'll add one more thing as well for insured populations. Some states have done a really good job of verifying identity electronically, which certain provisions of the Affordable Care Act allow you to build systems to do, where it pings other systems. Unfortunately, the great promise of electronic pinging across silos hasn't fully been realized in most places, but in theory, it's a great idea.
Great, thank you both. At this time, we have no further questions entered into our chat box, so I'd like to thank both Kevin and Brooxanne for your presentations today. And for those who attended, thank you so much for joining today's webinar. The presentation slides and a link of the archived webinar will be sent to all attendees within 3 business days, and an evaluation survey will be delivered to you via email. Thank you all. We appreciate your time today, and this webinar is now closed.